Greetings and welcome. I'm Steve Clemens, editor-at-large of The Hill. Thanks for joining us for our virtual event today, Policy Prescriptions for Cost and Coverage. We'll be taking a look at our current healthcare landscape and examining what patient-focused solutions are needed now and in the future. Before we begin, I'd like to thank our sponsor, Pharma, the Pharmaceutical Research and Manufacturers of America, for its support of today's event. Even as COVID-19 vaccines bring hope that we can hopefully soon start living something close to our normal lives, the reality is that on the healthcare front, our long-standing challenges are still there. They'd never really gone away. They'd retreated into the background for a bit, but now as we begin to see a light at the end of the tunnel on COVID, the old issues are coming to the forefront again. High out-of-pocket costs and surprise medical bills remain a top challenge for patients, as does their ability to access quality health insurance that meets their needs. How are we addressing cost and coverage concerns that existed long before the pandemic? And how can we ensure resiliency so our healthcare ecosystem can adequately meet the needs of the patients it serves? We've got a fantastic lineup of speakers to answer these questions and more, including members of Congress and patient advocates. But first, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag TheHillPolicyRx. That's The Hill Policy RX. We're broadcasting live and we'll be taking your questions throughout the program. And as with any live stream, you could have some problems. And I'm told if you just refresh the video, it will all be great. I hope that works for you. My first guest is Congresswoman Lisa Blunt Rochester from Delaware, a member of the Energy and Commerce Committee. She also serves on the new Democrat Coalition's Healthcare Task Force, and I love talking to her when she comes to talk to The Hill. So great to see you, Congresswoman. It's wonderful to talk to you. And first of all, I want to kind of bring our viewers' attention to an act that you have submitted that, as I understand it, helps guide states and whatnot in bringing new technologies, telehealth into place. Is sort of looking at the way our healthcare ecosystem has had some game-changing moments, and what you're trying. It's called the TIKES Act. Tell us about that.
Well, first of all, Steve, it's great to be with you again, and especially discussing a topic that is just so important to me. I mean, it's the number one issue that I hear about from my constituents in Delaware pre-pandemic and now during the pandemic. And so healthcare is definitely number one. And the TIKES Act that you referenced really is something that is focused on really an outgrowth of the pandemic. I mean, the topic here of patient-centered solutions is really positive and powerful, because what we've seen during this pandemic really can inform the solutions for tomorrow. There are many things that we've been talking about pre-COVID. We've been talking about telework, telehealth, distance learning. And I even started a bipartisan future work caucus because of those things. But it really wasn't until this pandemic that we pushed things that really have helped be patient-centered. Our TIKES bill is really a bipartisan bill that is focused specifically on ensuring telehealth services for young people, for children. But we have also seen in a bipartisan way a real focus on expanding telehealth across the board for everyone, particularly during this pandemic. And so I'm really pleased to see that we're getting some momentum, and especially that it's bipartisan, because those are the things that we hope will be able to be instituted and to stay, and that will really have an impact on folks.
I keep having to remind myself that if we had been having, under normal conditions, without Operation Warp Speed, without genetic coding, without a lot of the things that have evolved, we might be having this conversation that we were finally out of the tunnel on COVID in maybe 4 or 5 years after it hit. We're a year out. I mean, which is somewhat remarkable. So I understand that the need was great. A lot has moved in a very short period of time. But we're talking about these underlying conditions, and I think I'd be very remiss if we weren't talking about the inequities in our healthcare system, people left behind on the sideline, marginalized communities. All of that existed. And I think we've been trying to deal with a lot of that in COVID, and you're kind of looking at lessons learned. But when it comes to costs, and when it comes to access to healthcare for these communities, which I know are high priority for you, what would be the top of your list of the things that would really matter to them?
Yeah, what a great question. I mean, again, back to the lessons learned from this pandemic. I mean, we've seen that people of color, Black, Brown, Indigenous, or living in low wealth communities have been disproportionately impacted by this pandemic. And as I even thought about this focus on patient-centered, care and solutions, there are like a few C's that popped into my head. And one you mentioned, which is access to care. I mean, this pandemic showed more than anything how important the Affordable Care Act and having access to that care really is. And I was so glad that the Biden administration was able to expand that open enrollment period to let people to have access to the care. But we also know that if you don't know it exists, then what good is it? So the second C would be communication. I had a bill that we introduced in the previous Congress because the marketing and outreach for the Affordable Care Act had been slashed by 90%. And so our bill, the More Health Education Act, was really to get the word out about what exists, because that also increases the pool of people who are in the Affordable Care Act, which could help lower the cost, which is the third C. We know that one of the things that is, as we look forward, is to not just look at the volume, but to look at the value of the services that we provide, and that looking at new and creative ways of reimbursement so that it's focused on value instead of just the volume. And then the fourth C that I thought about was culture. And this is a big area, and it really gets to even some of the inequities, some of the vaccine hesitancy, many of the things that we've heard about as we've gone through this pandemic. And so one of the bills that I introduced was even to help expand and diversify the HIV staffing and making sure that there are more individuals. That's a bill with Barbara Lee, and it was John Lewis's bill that we took up. In addition, I did a bill that is hopefully going to expand for veterans, culturally competent mental health providers. So again, if you look at all of these, the fact that people need access to care, that we have to know that it exists, and we have to communicate in a way that gets it out to the people in ways that they can hear, understand, and receive and use. Cost. If you can't afford it, you don't have it. And then the last thing is to make sure that we're culturally competent in how we do it.
I really appreciate you talking about people needing to know about it. I mean, the communication side of this is important, the literacy side. I mean, it's daunting, to sometimes figure out medical billing, what's covered, what's not covered. And we seem not to have had a culture where that kind of transparency was automatic, in some ways. And I've got friends that work in, great hospital systems in which they really focus on transparency, but there are other hospital systems that don't. When you kind of look at the sandbox of players in the healthcare system, and that's insurers, and that's the pharmaceuticals, and that's the, PBMs, the pharmacy benefit managers, lots of players in this, do you have a sense that it's still a tug of war between some of the players? I know that lots of people have been hit by deductible changes, and that social contract, even for employer-based health insurance firms, changes a lot for people, and so they feel the impact more. I know Medicare is also having some of these issues. So it's a long way of asking you, do you think the situation is leaning in a way in which this is improving, or is this still a kind of zero-sum struggle between a lot of these players, and it's going to require government to get in and square this?
Wow, that's a big question. That is a big question because,
first of all, it's comprehensive, right? I mean, it's a comprehensive problem.
Exactly. I mean, you're talking about, it's systemic, it's institutional. And again, I think what the pandemic has done is shaken things up. Everything from just looking at data and what data we collect and how we collect it, that at the beginning of this pandemic, in my state, I said we're collecting data on gender, geography, age, but we weren't collecting data on race and ethnicity, which turned out to be one of the biggest indicators. And so even getting the whole system to say, hey, we've got to be in this together is really important. Us passing a surprise billing bill, that was a lot of tug, I'll just say tug, and across the board. But I think that at this point, we understand that We can't keep doing things the way we've been doing them and expect to have good quality of care and also lowering the cost. And so that's why I think you're hearing more about innovative ways to how do we reimburse, innovative ways on how do we provide services, even looking at something called the social determinants of health, which is where we live, where we work, do we have a food desert that impacts the healthcare cost. Is something that we are now looking at together and saying, hey, Medicaid, we should do things differently. Medicare, we should do things differently. And that includes everyone from prescriptions to insurers. And I have hope. This moment through this sadness gives me hope for potential change for a better future for our healthcare system.
Can I just ask you finally, this is probably a really unfair question, but you're from Delaware. I'm in Delaware a lot, by the way, Eastern Shore, but the President of the United States is from Delaware. You've got a great couple of senators, Carper and Coons, from Delaware. Delaware is now on the map in a big way. And, as we talk about patient-oriented healthcare and that, I'm just wondering, are there any kind of rabbits up your sleeve in Delaware where you folks got it right, or at least maybe, solving problems with communities that have been marginalized? Is there anything you can share with us by way of stories in Delaware that you think are cool that will become replicable for other parts of the country? Because we're all going to be looking at Delaware a lot more than I always looked at Delaware, but the whole nation will be looking at Delaware.
I appreciate you for saying that you didn't just see us as a train stop on Amtrak. I appreciate you saying that. But I will say, the great thing about Delaware is that we are really a microcosm of the country. We're urban, suburban, rural. We have tourism with our beaches. We've got farmers. I mean, we've got it all. And I think that one of the things that has been really just so exciting for me is to watch how we are tackling something like vaccine hesitancy. The fact that, and part of it is our size, that we know each other. And so there are, our lieutenant governor has these meetings with diverse communities to find out what are the creative ways that we can get vaccines and shots into arms. And to see us going into churches, to see us do these different things is very exciting to me. There's also, I don't want to let the cat out of the bag, but there will be some new news coming out potentially later in the week about an initiative that's happening from a bigger healthcare perspective in our state as well. And so again, I think our size helps in terms of communication, because that's the other C that I mentioned. But we, like everybody else, we feel like this is our moment to really tackle those issues of access to care, those issues of cost, making sure that we're culturally competent and that we communicate out what it is that people need and want. So yay, Delaware. Thanks so much for giving us a shout out.
Well,
and yay, President Biden, and thank him. I am grateful for the work that he and his team are doing as well to address these issues.
Well, Representative Lisa Blunt Rochester, I have to say vigorously that I believe that all cats should be let out of bags. But member of the Energy and Commerce Committee, member of the New Democrat Coalition Healthcare Task Force. I always love our conversations.
It's a reason to come back. It's a reason for me to come back.
Great. I look forward to that. Thanks so much, Lisa. Really appreciate it. Thank you so much.
Bye-bye, Steve.
And now a message from our sponsor, Pharma. Please welcome Lori Riley, the Chief Operating Officer of Pharma.
Steve, and thank you to The Hill for sponsoring today's important conversation. Last year, America's unique ecosystem was able to deliver COVID-19 vaccines and therapeutics in record time. But last year, we also learned an important lesson, that we have a long way to go to improve our healthcare system for everyone. Work is underway to ensure that medical advances are available and accessible to those that need them. Today, I'm lucky to be joined by Benji Fido. Benji is a caregiver to his son, Antonio, who is 13 years old, who was born premature and today requires treatments and therapies to improve his quality of life. But unfortunately, Benji has faced challenges with insurance that are far too common for many people across our country. So I want to thank Benji for joining us today. And I'd like to start maybe and hear a little bit about Antonio's condition and how Benji and his family have navigated COVID-19 with Antonio. So thank you again, Benji, for joining us. And if you can share a few thoughts on how you've adapted to COVID-19 and a little bit about Antonio's condition as well.
All right. Thank you for having me. It's a pleasure to be here. Antonio, was born 25 weeks gestational, so 25 weeks early. He has a Mickey button, which allows him to eat. The trach was put in November of 2007. We got it taken out, I believe, in 2016. So he has a stoma. He still has the feeding tube. He's missing half of his right lung because there were problems with that. He's had his diaphragm extended. He's had pneumothorax, so he's had chest tubes put in. He's last time he was hospitalized, we're going to knock wood on that, was in 2015, and he had to go back on a ventilator. He does have breathing issues, so he's susceptible to pretty much any respiratory issue. With COVID, it has been interesting. We've had to insulate him a great deal and insulate ourselves with people we're around. At school now, when he goes to school, he has to wear a face mask, and he wears a gaiter around his throat to protect it. Now it's a face shield when walking the halls. So COVID's made life interesting, to say the least. With all the safety protocols and everything, like I stated, we don't take him outside of family.
Well, thank you for sharing that. And I'm glad to hear that it sounds like at least you've been able to keep Antonio and your family safe during the pandemic that we've been experiencing over the last year. I was hoping maybe you could talk a little bit about how medical innovation has helped Antonio and improved his life thus far.
Tremendously. If it wasn't for medical innovations, he would not be alive. Advances they've made in helping him to breathe when he was on a concentrator, or different pulmonary drugs that he takes, which are numerous, as I stated, because he's missing part of a lung, and it's made his quality of life 1,000 times better. If it wasn't for people working every day in laboratories or different places to try to help him, he would still be on a ventilator concentrator. There's all these innovations happening because of people in laboratories, and it's fantastic, and it helps us, it helps him, and it's going to help him later on in life to be more normal.
And obviously, having the innovations approved and available is really important, but making sure that people can actually access them is really key, right? The best innovation in the world doesn't matter unless you can actually access it as a patient. And I know in the past, you and your family have had challenges being able to access therapies, whether it's insurance coverage or the like. Can you talk maybe a little bit about how important access is for you and your family and for Antonio?
Tremendously important. We've had to fight hard for a lot of stuff that he needs. Nursing, different surgeries that he's had, because insurance feels that, it's not necessary. He doesn't need that, and he does. And it's just banging your head against the wall till somebody hears you, and it's very frustrating. We had a problem with an pre-existing condition his insurance company didn't want to cover. They've been covering it for 13 years. They wanted to stop, and that was just devastating because it's an expensive tool, and I don't have $1,200 a month to pay for that. We rely on insurance. And it's just, he doesn't need it anymore. No, he needs it, or we wouldn't still be getting it. And that needs to change. We need to have easier access without going through prior authorization, without talking to 15 different people before we get the answer we want, not having to write letters and having to call people. It's very frustrating.
Absolutely. I wanted to ask you a question. How does it make you feel? Obviously, there's a lot of talk in Washington and the states these days about potential changes that could be made to our healthcare system. And arguably, some of those changes could make it harder for patients to be able to access therapies they need, or they could do things that may come in the way of progress and innovation, the kinds of treatments or therapies that might be important to Antonio or other patients. How does that make you feel when you hear folks in Washington or in the States are thinking about proposals that might put barriers in place to access or make it harder for some of those innovations that you've relied on to come to be?
Makes me angry because they haven't walked. The old adage is you got to walk a mile in my shoes before you can understand, and they don't understand what it's like when I'm going to go back in time in 2015 when he got really sick and we didn't know what it was about. Just to get him to be put back on the ventilator was a pain. The hospital did it, and then they're like, "Oh, your insurance might not cover it." Huh? Why not? Well, because he hasn't been on it in so long and they feel we're overstepping. No, he needs it. Don't change. He had surgery on his legs. And just to get PT was a trial for that. And if things change, you're going to make it harder. His quality of life is going to suffer. I'm going to be spending more time on the phone. His mother's going to spend more time on the phone. We're going to be more emails, more meetings in person. Don't make it harder. It doesn't need to be made harder. It's hard enough.
Well, unfortunately, I think many people listening and many people across America can empathize with the challenges that you and Antonio have faced, because unfortunately they have faced them too when it comes to accessing care and treatments that they need. I really want to thank you today for sharing your story, Benji, and that of Antonio's with us. I hope you'll give your best to Antonio on our behalf. And thank you for continuing to fight and advocate on behalf of your son. As you described some of the challenges you face today, it's a full-time job providing care to a loved one. And then when you have to face some of the challenges, as you said, dealing with insurance companies, it just makes that burden that much harder. So thank you for doing what you're doing. And it's a big reason why Pharma released just last week a new proactive agenda to try and address some of the issues that we've talked about today. And there's really three key pieces of that agenda. The first really starts with preparation. How do we ensure that we have robust supply chains in the US? How do we continue to foster collaboration between government and industry and academia and modernize our research and development and manufacturing capabilities so that we can continue to bring the kinds of innovation that we've seen with COVID-19? But it also begins with affordability and access, ensuring that patients like Antonio can continue to benefit from the rich and robust innovation that our country has brought to bear. It means addressing some of the policy challenges that patients face today. For seniors, it might mean capping their out-of-pocket costs so that they can afford to receive the types of medicines they need. It means lowering cost sharing so that patients cannot not just access innovation, they can afford the innovation, and ensuring that their costs are predictable so that they know what they're going to pay when they show up at the pharmacy counter. And it also means ensuring the rebates and discounts that our industry offers to insurance companies and pharmacy benefit managers make its way back to the patients when they're sitting at the pharmacy counter and not kept by insurance companies and middlemen. And last, it means enhancing equity. We do need to do more to improve diversity in clinical trials, expanding our outreach and education efforts in minority communities, and building a more just and equitable system that recognizes, measures, and promotes better health for all communities. I think medical innovation is an important success story in the US, and it's one that we should never take for granted. And through these common sense solutions, we believe we can work together with lawmakers, both in Washington, DC, and around the country, to ensure that we strengthen our healthcare system and make healthcare, including medicines, more affordable for all. With that, I'll turn it back to you, Steve, and thank you very much for having us today.
Thank you so much, Lori and Benji. It's really great, and I just want to thank Benji for his candor and willingness to share, because we have a lot of these discussions in Washington, but it's so important to think about people who are going through real world health challenges and how we need to improve things. So thank you so much. Up next is Congressman Rodney Davis from Illinois. He's a great friend of the Hill. He co-chairs both the Colorectal Cancer Caucus and the Task Force on Childhood Obesity. Congressman Rod Davis, thanks so much for joining us. That looks like a cool room behind you. I'd give you 10 out of 10 on Room Rater. Let's talk for a minute. This is completely uncoordinated. I mean, our supporter today is pharma, but completely unrelated to that. I just got an alert a few minutes ago, happened to come from pharma, it's unrelated. It says West Virginia becomes the first state to lower patient costs by sharing the savings. And in this, they're talking about pharmacy benefit managers and insurers have been able to negotiate down, the price of various drugs for patients, but those haven't always gone back to the patient himself or herself. And West Virginia unanimously in their legislature passed a law that said some of this needs to be shared with people, and they've lowered the cost. I find it fascinating. I didn't know about this, and it's interesting, and it makes a degree of sense to me. Do you think that we need to see more? Perhaps, I know you may not have prepped on this, but on West Virginia, what it's done to say to those folks, if you're out there, negotiating better deals, part of that's got to get back to that to Benji's son.
Yeah, no, Steve. Hey, I expect this out of you, my friend. You give me a list of questions. You want me to prep for it, and then you just throw me a curveball. But that's okay. That's what I'm here for, and it's great to see you again. I would have to see what the West Virginia proposal actually does to determine whether or not I think it could be put in other states. But we do have a problem in this country of where savings are not passed on to maybe local pharmacies to be able to get those drugs into the hands of people in the rural communities in my district that may not be comfortable with using mail-in programs or other things that could lower their cost. These are the types of things that we have to continue to work on in a bipartisan way with the goal in hand to lower prices for the consumers in the end, which from what you're telling me is what they're trying to do in West Virginia.
Yeah, well, I appreciate you willing to take my left field answer. I think you answered it beautifully. But look, you've been focusing, I know you and I have talked about the whole healthcare spectrum, but you've been focusing on colorectal cancer, on childhood obesity. Recently I talked to Congressman Peter Welch, whom you know well, about, his former wife and struggles with cancer. And so I just want to continue to put people at the center of this. But can you take us into a journey on your work on colorectal cancer and childhood obesity and why it's so important to you?
Well, my journey on colorectal cancer is personal. My wife, Shannon, who is friends with Congressman Welch, too. We've traveled together on numerous occasions, and we've heard his story. But her story began 22 years ago as a 26-year-old nurse who couldn't walk up a flight of stairs without becoming winded. She was told that nothing's wrong, it's in your head. Eventually, she forced a blood test, which showed she was severely anemic. And after trying other remedies for diseases she didn't have, she finally got a colonoscopy, and they found a tumor. Luckily, she got it at stage 2 because she was her best advocate. And 21 years later, after surgery and 6 months of chemotherapy, she's still running strong. But she has a genetic form, Lynch syndrome, which could impact our kids, could impact grandkids, could impact others in our family. So we have to continue this fight. And the good thing is, my wife was able to survive, and we see more survivability in the last 22 years for a disease like colorectal cancer. But research is key. Research has been key for that survivability. And research clearly shows, Steve, we got to do a better job on childhood obesity, and the pandemic clearly has not helped that.
When you take your wife or others suffering from this, I was down in Baton Rouge once doing a program on obesity, and I have to tell you, I met the best people in the world. I couldn't believe, but the fatigue down there of dealing with, something that being in chronic, looking at multi-generational questions was very big there. And as they were dealing with various health impacts from this, they were running into insurance blocks. They were running into surprise costs. They were, the broad cost dimension. And then there's what I was talking about, Lisa, Blunt Rochester earlier, is just the literacy, just being able to understand how to navigate the system. So when you talk to people out there and you're trying to sort of tackle, cost and the insurance dimensions and various things, what's highest on your screen of things that are actually doable in terms of adjusting the cost picture for patients?
Well, a lot of times, and you're right, and I'm sure my colleague Lisa Blunt Rochester would agree that there are things that we've done that have really come together in a bipartisan way. But because they were bipartisan, Steve, I don't think they got a lot of attention. We came together and ended surprise billing. That's something that's affected me and my wife and our family in the past. And it's a very frustrating issue for families to think that if you went into a hospital or a clinic that was covered by, or an emergency room for that matter, in our case, that was covered by our insurance company at a hospital that was on their list, but somehow the ED doctor that you didn't get to choose was not, and you had a skyrocketing bill, that helped us lower healthcare costs. I also want to make sure that we address copay accumulators. If for some reason a pharmaceutical company is willing to help one of my constituents lower their cost for a drug that they need to survive, then insurance companies ought to count that towards their deductible and costs going in, rather than taking that cost out and in the end costing my constituent and other Americans more. These are two ways that we're working together to ensure we bring down the costs. But unfortunately, healthcare, Steve, as you know, when we debate it, gets caught up in this debate over Obamacare or the Affordable Care Act, instead of actually saving families money on the cost of healthcare. And we've got a long way to go.
Where are we, Rod, now on telehealth? Is that now so embedded in the system? I mean, we've gone through a year where telehealth replaced a big chunk of the healthcare system. I assume it created efficiencies. And I know with reimbursements it was, given certain waivers. Is that secure now, or is that something that we need to worry about keeping as much a part of the U.S. healthcare system as it has been this last year?
Well, our goal is to continue to highlight the benefits of what we learned during this pandemic. And one of them clearly is what you just mentioned, the ease and access to telehealth. And it's something that I hope does not go away, because if it's effective during a pandemic, then why wouldn't we keep it? We've allowed now our medical facilities to count and get reimbursed for telehealth visits via FaceTime, via Zoom, via WebEx. I mean, really, which has become our life in this business. Why in the world would we require individuals to go to a location in the future to have costs getting there and to use a certain type of a machine when we clearly have been able to do it through technology that's convenient for the patient? Let's make sure we continue to keep these. The only way I can see it going away is if you have a rogue bureaucrat, and I'm looking right outside my window above my computer right now at HHS, if somebody over there decides that they want to go back to what we were doing before the pandemic, and I think I'll probably lead the charge to pound on some doors over at HHS to say, hey, let's rethink that if they ever do it.
Congressman, I know you do talk with your colleagues across the aisle. You work in a bipartisan way when you can, but you're also not shy about drawing a line when you think something's wrong. So with the Biden administration has come in, and as they've approached, they've been in now long enough, to sort of show some of the terrain they're going to go into and, what methodologies they're going to bring to the health picture. Are there any blind spots they have that you would counsel them not to have?
Believing that somehow states in the long term are going to be able to afford continued expansion of Medicare expansion, or Medicaid expansion. States like my home state of Illinois are in for a whopping bill once the COVID money train goes away and once some of the increased investments into our Medicaid system go away. And those are some of the issues that I know state leaders need to focus on, but we need to take a look at some of the policies that we put in place over the last 8.5, 9, 10 years that are going to cost states dramatically more unless we actually put some reforms in place that are truly going to lower costs for most Americans when it comes to healthcare and give them the access to the healthcare that they deserve.
Well, Congressman Rodney Davis of Illinois, co-chair of the Congressional Colorectal Cancer Caucus and the Task Force on Childhood Obesity, engaged in lots of healthcare policy. Thank you so much for joining us today, Rod.
Hey, great to see you again, Steve. Can't wait till we get together again in person.
Look forward to that. My final guest is Keisha Brooks Coley, the Vice President for Federal Advocacy and Strategic Alliances at the American Cancer Society Cancer Action Network, also known as, if I'm getting this right, ACS-CAN. Keisha serves as head federal lobbyist for this advocacy arm, and we're excited to have her with us today. Keisha, thanks so much for joining us. I don't know if you heard the conversation I had with Congressman Davis, and he's been working on colorectal cancer, but on a variety of other things. And, I always lucky to meet fascinating individuals who are trying to make a difference in people's lives. But one of the things I wanted to do today was to sort of get an understanding of how the patient sees this environment he or she may be in. And so I'd love to hear from you as you're kind of looking at patient advocacy and what our audience needs to know about what's not there for them and what they really need as opposed to what's prescribed necessarily. What are some of those things?
Sure, and thanks, Steve. Appreciate your invitation to allow for our voice to be included in this conversation. And your question around the patient environment and what is important to the patient right now. What's important to the patient right now is access. And it's access to affordable and quality health insurance and access to making sure that they can be able to receive the treatments and innovative cures that are so important for cancer patients. And coming now through COVID, I think we all have seen our healthcare system in different ways. And from the patient perspective and from ACS CAN's perspective as a patient advocacy organization, we are looking at it through that new lens as well. We're looking at it through the lens of making sure that people have access. We know that when your cancer is diagnosed, your treatment outcomes and your survivorship rates are based on your access to health insurance. We know how important that is. We also know that we need to be looking at a lot of the important healthcare issues that we're talking about currently through the health equity lens. Through COVID, we saw that health issues impact different populations differently, different individuals differently, and we have to look at how minorities are impacted by healthcare issues, especially through cancer, and that's something that ACS CAN has done for many years, and we're looking at it even more closely because from the patient perspective, we know that it shouldn't matter where you live or what community you're in, what your zip code is, the type of healthcare that you receive should be the same. It should be affordable. It should be quality, no matter where you're sitting in this country.
Keisha, let me ask you a question, and I may mess this up, but I am just too aware that many people of color who go into the healthcare system are not treated equally and do not have the same experience. We've interviewed many of these people on this show, and we know that data don't lie, and the data show difference in life expectancy, difference in impact. We saw this with COVID. We've seen it in, maternal mortality, a lot of fronts. And so I guess my question is, what do we do about it what do you do about it with your patients when they're not getting that fair and equal experience that, others in American society are getting?
Really important question, Steve. And it's something that ACS CAN has been looking at very closely over the past few months. As you said, we know we have evidence-based research that shows, even if you just look at the cancer side, that cancer patients, dependent on their race and ethnicity, oftentimes, as you noted already, don't have the same outcomes, even though they have sometimes even often have insurance, and when you take insurance into consideration, they don't have the same outcomes, and it's a question of why. What is leading to these disparities? And ACS CAN, along with the National Comprehensive Cancer Network and the National Minority Quality Forum, actually engaged in a project a number of months ago to engage cancer patients and survivors and oncologists to look at these issues more closely. We did survey work that showed that minority patients feel that they don't receive the same type of care as their white counterparts. That's a question of why. How do we address that issue? And oncologists also stated that they felt like they had actually participated in issues around bias and interacting with patients differently based on race, and that's an issue that has to be addressed. From the project that we're working on, we have a number of policy changes that we're looking at to make sure that the healthcare system is one that individuals from diverse backgrounds can have a better opportunity to be engaging with their healthcare system with better outcomes, looking at the issue of making sure that clinical trials are diverse, making sure that patients have access to patient navigation services so they can actually navigate the healthcare system, something that has shown that when minorities have access to those types of services, then their outcomes are better. And then also looking at screening and the need to make sure that everyone has access to screening and increasing more funding for programs such as the National Breast and Cervical Cancer Early Detection Program that provides life-saving screenings to women who don't have access to coverage. So we know what the problems are, and it's really actually it's a good time to actually be able to be in this climate where a lot of people are focused because of COVID on many of these issues, ones that are not new, ones that many of us in the advocacy space have been working on for many years, but it's definitely a moment in time.
Well, I really appreciate your candor on that. I know it's a tough issue, and I've talked to so many people, and I think COVID, when you look at the Native American community, look at Black and Brown communities, others, there have been efforts. We'll have to see whether they work, but at least has been discussed a lot of, kind of took it. You wonder how not to lose the momentum of at least the the perceived need to reach every community, but I remain skeptical, as you sound as well. Hopeful, but skeptical. But
absolutely hopeful. It's a moment in time, and definitely hope.
Yeah, hopeful. Let me ask you. If you were to advise the Biden administration on how to square some of these circles on cost and insurance and affordability and access, what would be some of the things you would like to see the Biden team take seriously?
Sure. So I think from our organization's perspective, it was great to see a number of provisions that were included in the Rescue Plan Act that passed a few months ago, addressing issues around cost and access, making sure that individuals at a lower FPL have access to subsidies to allow them to be able to purchase insurance, increasing the FMAP for Medicaid, to incentivize more states to move forward to expand Medicaid. We know that those are ways that we can actually make sure that more people have access to coverage. On the affordability side, cancer is expensive. We know that cancer patients actually paid over $5 billion in out-of-pocket costs in 2018, and which is the most recent data that we have. And that's an issue that has to be addressed. One of the things that ACS CAN has had longstanding policy on, for example, is having a cap on the Part D program and making sure that individuals who are in the Medicare program have a cap on their out-of-pocket expenses for their drug costs. And so those are a couple of things that we're looking forward to continuing to have conversations about and continuing to advocate for. The last thing I'd mention too, because I think it was clearly something that was extremely important that was included in that bill, was even just having the special enrollment period open, which yielded over 500,000 people across the country to be able to access insurance. That was something that we had advocated for a number of months last year, that has allowed for more people to have access, which is, from our perspective, life-saving access to care.
Keisha, is there anything else on the cancer front? Again, you're talking to Rod Davis, talking to many members of Congress on cancer. Cancer is so pervasive in many ways. There have been a lot of gains made in terms of extending life, cancer remission. Basically, we're living at the same time that we're living with all these incredible technological achievements in health. We're also kind of dealing with, incredible fragility in how it's deployed. But I'd just love to say, if there's anything else that you'd like to share with the patients on, that cancer patient and helping him or her navigate it. I know you used to work in the Senate, and I always wonder, how do you make the link from the policy battles in the Senate to that individual who's got cancer? What should we hear?
Sure, Steve, and I think you make that connection with the patient stories. We always lead with our patient stories, even as someone who is a professional lobbyist who's advocating on behalf of our volunteers. Our volunteers speak well for themselves as well, though, and tell the story of why the policy changes that we advocate for every day are so important. And I think one of the last things I would leave you with as an issue that is extremely important for us, that is very much top of mind and is encompassing our health equity and health disparities work too, is access to screening. Again, with COVID, we're looking at things in very different ways. We know that the screening rates have been declining. They're starting to inch back up, but we know that cancers have been diagnosed later or will be diagnosed later because of COVID. The American Cancer Society has a Back to Screening initiative to make sure that Americans know that they should be looking at how do they safely make sure that they're getting their cancer screenings. And that ties into our work that we'll be doing for advocating to increase funding for the National Breast and Cervical Cancer Early Detection Program that the CDC actually initiates across the country. And that issue is one that is just extremely important for us. It's all about prevention, as we know, but prevention is only as good as people who have access to those life-saving preventive screenings. So that's one issue. But again, the patient story is what we lead with, because we know that cancer touches almost everyone's lives and many, many people across this country.
Well, Keisha Brooks-Coley, Vice President of Federal Advocacy and Strategic Alliances at the American Cancer Society Cancer Action Network, ACS-CAN. Thank you so much for joining us today and sharing your thoughts.
Thank you so much, Steve. Appreciate the opportunity. Take care.
Take care. That brings us to the end of our program today. A big thank you to Pharma for its support and all of you attendees for joining us for this discussion. For those of you who missed any of the conversations, we're going to have this video up from the event on our website shortly. You can watch it all there again or share with your friends. I'm Steve Clemens. Be well.